We are
We welcome you all to this webinar on quantitative quality of intraocular pressure control in glaucoma management. And today we have a galaxy of speakers with us from both who are of national and international repute. It is my privilege, my honor, my pleasure to introduce the first speaker, Dr. Harsh Kumar, who's been awarded the Padma Shri by Government of India. He is currently the Director of Glaucoma Services at Center for Sight, New Delhi. Formerly Additional Professor Glaucoma Unit, RP Center, AIMS. Formerly President Glaucoma Society of India from 2010 to 2012, has numerous publications in the international index journals, has 3 books and innumerable chapters to his credit related to the glaucoma work. He has several laser procedures for glaucoma and anterior segment, which have been described for the first time in the world literature, and this is also cited in the Shields textbook of glaucoma. And he was conferred the International Medical Scholars Program Award with a fellowship at the University of Illinois at Chicago, USA. Personally, sir has been a teacher to all of us in RP Center. And like I was discussing earlier, first day when I met him on the corridor, I thought I had met not assistant professor in ophthalmology, but my co-JR. And he's otherwise so friendly and so approachable that anybody can, go to him and ask him any questions, any doubts, and he's always available. It is my pleasure to introduce Dr. Ronnie George, uh, my co-moderator, who's currently the Senior Consultant and Deputy Director of Glaucoma Services at Shankar Nethralaya in Chennai, Research Director at Medical and Vision Research Foundation, Shankar Nethralaya, Chennai, has more than 80 publications in peer-reviewed international journals and 8 book chapters. He has delivered numerous lectures at various conferences as an invited speaker and has been clinical investigator for a number of population-based epidemiology study, which includes the Chennai glaucoma study and the Chennai glaucoma follow-up study and the Chennai eye disease incidence study. He's also been a part of Indo-US project, which is related to glaucoma a few years ago. And he's also the associate advisory board member for World Glaucoma Association and has been the past secretary of Glaucoma Society of India. I would now request Dr. Ronnie George to make the next introductions. Dr. Ronnie, I can't hear you. Are you muted?
Yes, sorry. It's a pleasure to welcome Professor Shamira Pereira. Shamira is Senior Consultant Ophthalmologist at the Glaucoma Service at SNEC. He's also the Director of Clinical and Surgical Innovation at SNEC. He's actually an excellent surgeon, and his videos are worth watching. He's a co-head of the Bioengineering and Devices section in SERI and the Deputy Director of the Medical Tech Office at Singh Health. He has published over 100 papers, 4 book chapters, hold 8 patents uniquely, and has co-produced an award-winning app. His other notable achievements include the Silver Award of the Singapore Health Quality Services Award, the Manpower Capacity Development Project for Eye Care that he had won the 10th AHIP GEM Award, and he also has a Program Innovation Award for the AMEL Golden Apple Towards Touch Surgery Cataract App module. It's also a pleasure to introduce Dr. Chandrima Paul. Dr. Chandrima is the Director and Consultant at the Glaucoma Service of the BBI Foundation, and we congratulate her on her recent appointment as the Honorary General Secretary of the Glaucoma Society of India. She's also unique in having a PhD in ophthalmology from the RIO Calcutta and has been awarded the FRCS by the Royal College of Physicians at Glasgow. She is trained at the Glaucoma Service of the Moorfields Eye Hospital, London, UK. She's a recipient of many awards, including the DB Chandra Award by the AIOS, the BK Mitra Award by the Ophthalmic Society of West Bengal. She's been a chief instructor, chairperson, and faculty at the WGC in 2013 and 2015, and a speaker at glaucoma sessions of both the American Academy and the European Society of Cataract and Refractive Surgeons. She's a versatile surgeon and has performed live surgery multiple times and has delivered named orations at prestigious ophthalmic congresses. She's also conducted the Hooghly River Glaucoma study, which I think with approximately 15,000 patients is one of the largest glaucoma prevalence studies published till date. She's also a principal investigator on multiple phase 3 trials for anti-glaucoma medications and neurosurgical tools. I didn't know this, but she's an ardent pianist, debater, and globetrotter. The second and the third I knew, but I didn't know the first. So welcome, Dr. Chandrima. It's good to have you on board.
I would now request Dr. Rajesh Sinha, who is the Professor of Ophthalmology at RP Center and Treasurer of All India Ophthalmological Society, to make the next introductions.
Thank you, Dr. Namrata. A very good evening to all of you. It gives me great pleasure to introduce a dear friend, Dr. P. Satyan, who is currently director at the Satyan Eye Care Hospital and Coimbatore Glaucoma Foundation, Coimbatore. He has worked as medical consultant from 1993 and worked as chief glaucoma services for 15 years from 1997 to 2012 at Arvind Eye Hospital, Coimbatore. He has been an advisor for various national and international ophthalmic hospitals through the LICO program. He is ex-secretary, PSG Institute of Medical Sciences, and ex-chairman, Ethics Committee, PSG Institute of Medical Sciences. He is also the treasurer of Glaucoma Society of India for the period 2003-2004. He has been in the board of trustees in the PVKRN Higher Secondary School, Pongalore, ex-secretary, Coimbatore Ophthalmic Association. He is also ex-chairperson, Coimbatore Glaucoma Forum, Organizing Committee, Glaucoma Society of India 2012, and new product innovator for various equipment and drug manufacturers. And he has been kind enough to accept my invitation in DOS when he had done live surgery, and he has been a very good surgeon and has been presenting in various international and national forums. Again, it is a great pleasure to introduce a junior colleague of mine who has worked at RP Center with me, Dr. Shibal Bhartiya, who is a very dynamic lady, very innovative, very academic. She is currently senior glaucoma consultant and surgeon at Fortis Memorial Research Institute, Glaucoma and Fortis Rajandhal Hospital, New Delhi. She has done MBBS from Maulana Azad Medical College, has done MS from Maulana Azad, and has been senior research associate at Cornea and Glaucoma Services at RP Center, AIMS. And then she did senior clinical research fellow glaucoma services in the Department of Clinical Neurosciences at the University of Geneva, Switzerland. She has more than 100 published papers and has edited 9 textbooks on glaucoma. She is executive editor of the Journal of Current Glaucoma Practice and the editor-in-chief of Clinical and Experimental Vision and Eye Research. She has been part of various journals as in the editorial committee as editor, and has been a very proficient and efficient ophthalmologist and academician in the field of glaucoma. So thanks a lot to all of you for joining. And of course, we have Dr. Namrata Sharma, who is the secretary of AIOS. I must say that as Dr. Harsh was mentioning, I also get a lot of inspiration from her hard work. Try to work, hard as much as I can, but definitely not as much as she can. And she is a very dynamic secretary of AIOS, working as professor in the cornea and refractive surgery services at RP Center, AIMS. I welcome you all in this webinar, and now over to Dr. Ronnie and Dr. Namrata.
So, Dr. Ronnie George, I think we can now start with the presentations. Over to you.
So this webinar is basically going to look at quality to quantity, quantity to quality of IOP control and glaucoma management. Is going to focus not just on the mean IOP reduction that we are so familiar with, but also the quality of IOP reduction in terms of both the peak and the 24-hour IOP control. We'll talk a little bit about rational medical management and also quality in terms of side effects. And this time we're going to be focusing on hyperemia, which is a very common side effect that you see in glaucoma management. It may not appear to be an important issue, but it's actually a fairly important reason for non-compliance among patients. After this, we'll also have a little bit of discussion about how the molecule worked in India, because there's really no data on taflopros from India. And before we do all this, we will have probably one non-IOP related topic, which is so important in India, that is the optic disc assessment. Because with a dependence on an IOP-based diagnosis of glaucoma, we're going to miss most glaucoma. So it's a pleasure to request Dr. Harsh Kumar to tell us about optic disc assessment, making your cup of tea. Over to you, sir.
Thank you, Ronnie. Thank you, Namrata, for such a kind introduction. And thank you, Gyan, for having me in such an elite gathering. So are we okay with the slides? Are the slides on?
Yeah.
Okay, so let's start off. And the basic thing is that I still feel that each ophthalmologist needs to look at the disc. That is the very, very basis, because whatever you do or say, the basic marker is the disc for glaucoma. Why? Because so many cases, the intraocular pressure at the first visit may be normal. And now we are having so many normal tension glaucomas where the pressure is normal. So you just can't rely on the pressure. And as a matter of fact, pressure is not in the diagnosis of glaucoma. So how can you depend on that? Beyond that, I agree with you that perimetry is very, very important, but let us talk about India. Let's talk about Asia as a whole. And believe me, the access to perimetry is very limited. It's an expensive tool. All of us know that patients are very, very, they are really hecked up saying that it's such a difficult test. And the first time to get a right thing in it is really a tough job. Therefore, you must remember that the heart of glaucoma evaluation is the diagnosis through a disc. This was a gentleman around 54-year-old who came to me, thick corneas, fields were normal, disc the NRR was really healthy, the pressure and the diurnal variation was 20 to 24 because of the thick corneas. Since there was no family history, though he was a one-eyed patient, I thought, all right, let me just watch him. So called him later for after 6 months, but came in after a year, and I was quite shocked to see that though the fields were still normal, there was a wedge defect over here. What it taught me very clearly was that the structural damage is the first to occur. And then we went back and saw that the OCT, which was normal, has now deteriorated. So that told us that disc is an important, very, very important marker. But yes, I must accept that sometimes the fields may be the first marker. And especially in cases where there's a tessellated fundus, or it may be not very easy to look at the disc because of the cataracts and all, it may not be so always that you will detect the structural damage. But definitely a disc must be the first thing that you have to really look well into. And what are you looking at? Basically, what we are looking at is the neuroretinal rim. So it is the 1.2 million axons coming from the ganglion cells all around our retina, which get collected together in these bundles. And it is this neuroretinal rim we are worried about. All these axons are coming straight from the macula out here. Those from the temporal are going arching out up and down, while the nasal ones are coming the way we see them over here. And the best examination indeed is through a 90D, because it gives us a stereoscopic image on a slit lamp. But everybody has an ophthalmoscope, so nobody can say, I could look at the disc. That is not an excuse at all. Yes, 90D is the best. And what are we looking at? We are looking at the scleral ring. We are then looking at the neuroretinal rim, which is the thing to look at. But we do look at the retinal nerve fiber layers. I had just shown over there that this may be the first damage that you may detect. And then we are looking at the peripapillary atrophy. And then, yes, another important marker is the optic disc hemorrhage. Very, very important is in rule. I'm like Gyan told us, it is for general ophthalmologists. Please, even when I teach and I go back again and look at my discs, the best and the most important thing simply to look is in rule that the inferior disc is the thickest, followed by superior, followed by nasal, followed by temporal, and that is what you have to look at. So because the inferior fibers are the thickest, followed by superior, followed by nasal. And once you find that this is not okay, immediately you'll become suspicious. Forget everything else. This is something which you cannot miss. And the moment you look at this, then you see, oh, there's a wedge defect as well. All these things may again be missed because there are so many cases of tessellated fundus, etc. But this you are unlikely to miss. So please follow the ISINT rule. The color is also very, very important. It has to be pink. And it's very, very important. I learned quite late that almost 40% of the major studies have detected their glaucomas or the progressions due to fundus photographs. Obviously, there were stereo photographs, but since then I've already, in all my glaucoma patients, I add on, and all general practitioners, if they have a fundus photography, they should do it in all those cases. So assess the disc with dilatation, make sure there's no overexposure. Always do red-free photography, because that will give you the best images and the best chance of detecting the wedge defects. You must know the size of the disc. This is a problem that we face every day, that there are large cups, but you must understand that the size of disc varies between 1.4 to 2 millimeters. And if you have a Welshner ophthalmoscope, the small 5-degree aperture is equivalent to that disc size over here. But more important is that you are all seeing it through the 90D or a 60D or whatever you have. And over here, if you do a marking with the help of your slit lamp, you'll get the mark over here about how much is the disc. And then you can multiply by 1.3 if you are doing a 90D, which usually is there. Why do you want to do this? So commonly we see, anybody who sees a large cup says, oh, this is glaucoma. You'd see the other eye if they are symmetrical. It could be just a physiological cup. Look at this now. Okay, the cups are large, but the isn't rule is maintained. The NRR is healthy. The fibers are quite fine. The striations are good. There's no wedge defect over there. Obviously, if there's an asymmetry, you are a little worried that it could be glaucoma. So you immediately check up. But again, please have a look. Plus, please, before you start doing 100 tests and start wasting the money for patients, especially in Corona, the people are really handicapped as far as the money is concerned. Please be sure, please do your clinical examinations well. And as you can see, the disc here is smaller than the disc over here. So the larger cup is because of the larger disc. You do a field, you waste the money, and this is going to be normal. You do an OCT, it's going to be normal, and it tells you, yes, you are dealing with a larger disc, as you can see very well over here. And this is what is happening every day. I see small children, whenever you are taking a pressure, they'll squeeze their eyes and the pressure will be high. And the parents are crying and they are coming all over and saying, oh, sir, this year she has got glaucoma. The first thing you got to do is relax the patient, take a pressure very, very calmly and quietly, which will turn out to be normal in most of the cases. Check the NRR is healthy, everything is good. Make the parents sit down. And then you realize they are having similar cups. So it's just a physiological cupping which the whole family is having. If you have to investigate anybody, please do it to the parents, because they are having similar things. But day in and day out, people are doing so many tests on children, which is totally, totally redundant. So please be careful. Again, the parapapillary atrophy, especially the beta zone, where you can see the large choroidal vessels, because the RP is gone. And if this stretches out, that means this is the area where the field defects are going to occur. And this is important in some ways. The vascular changes are important too in some cases, because the general ophthalmologist can pick up that, okay, there's a bayoneting over here. Sometimes there is a bearing of circumlinear vessels, means there was a tissue or an NRR over here, which has now died, and the vessel is bared over here, which will later fall into the thing. There could be nasalization of vessels. Again, overpass cupping, the same thing. There was a tissue over here which is died, and this vessel is going to drop, causing bayoneting later. Splinter hemorrhage is a very, very important marker, more commonly seen in normal tension glaucoma. It will mostly proceed to nerve fiber loss and visual field loss. You have to be very, very cautious. It means that possibly there is a glaucoma, and possibly if there is already a proven glaucoma, then we are not treating the patient aggressively enough, and we need to be more aggressive on that. Obviously, the cause is not very clear, but people say that the rim tissue is deteriorating, and therefore the vascular architecture succumbs to that. Remember that ganglion cells in the periphery send their fibers to the periphery, and those in the center are coming from the central area. And therefore, if the pressure is over here, there'll be a paracentral scotoma. If there's rare, you'll have a central arcuate. If it is in here, There will be peripheral arcuate, and if it is just over here, you may get a nasal step. So if the whole rim is gone, you will have a beautiful total arcuate over here. So this you can really see. You can see the wedge defect over here, and you have to always correlate. So many times there will be things which may not be correlating. You may get a beautiful arcuate scotoma because of a BRBO. So if there is a clear-cut defect over here, there is an inferotemporal defect, there is a superior nasal field defect, you know that you are doing the right thing. Again, the NRR is almost looking healthy, but you look, there is a wedge defect over here, and then you realize that only the peripheral fibers are gone, so there is just a nasal step over here. You have to watch very carefully. Many a times the area which was looking normal, it may not be in the periphery or in these areas, but again, this becomes suspiciously bad. Same way you can look at the notch which is increasing over their years, and that is the fun of doing a serial photography. Be very, very careful. If you get pale discs which are not much cupped, the first thing in India that you have to think, am I dealing with an angle closure glaucoma? This is Dr. Ramanjeet's paper, and it clearly shows that many of the glaucomatous discs of angle closure glaucoma do not have a serious cup, but they are quite pale. But yes, obviously, the other thing we'll think of is a neurological disease, which could be neuritis, ischemia, granulomatous, hereditary, traumatic, toxic, irradiation, and whatnot. But most important indeed is the compression, and you have to do an MRI, and you have to look at the tumors, which could be anywhere, or it could mostly in the pituitaries. So you have to watch whether it's a pale neurological disc. Always do a gonioscopy. Myopic discs are really, really bad and difficult to handle because everything is stretched out. You can hardly make out the cup, and especially if the myopia is greater than 12 diopters, it's quite a mess. And what basically happens here is, because of the stretch out lamina cribrosa, the chances that the damage will occur even at lower pressures is quite high. So you have to be very, very alert. Obviously, the differential would be optic disc colobomas, or there could be a small pit, which you have to be very careful about. But basically, you should see that the rim, if the rim is not healthy and symmetrically there is a disc, there's a defect in the field, you know that you are dealing with glaucoma. And if you have large cups, like I showed you, with everything healthy, you have to go step by step, look at the striations, there's no wedge defect, NRR is healthy, they are symmetrical, you know that the fields and the OCT will be normal. So please remember the disc photos and the assessment of the disc along with RNFL is very useful in early glaucomas, but in late glaucomas, they may not be that useful, and the fields would be things that we should follow. So the take home message is, check for the size, please check for the size, check the neuroretinal rim, follow the ISNT rule, look for vascular changes, look for asymmetry, please document serially. And I must show, this is Dr. Rajiv Garg, who was our DGHS just now, and he has serially documented, having nothing over there with him, he has just documented with a pen and a paper how beautifully he's shown how the disc has deteriorated. And the disc is crying, please save me, so please follow it. And please, please, there is a request to all cataract surgeons, dilate the patient 3 weeks post-op, look at the disc. There's innumerable number of patients I'm getting which are post-cataract in which they are not been looked at, they have glaucoma, and this glaucoma has not been looked at, and they come to us when it is so far on that we really can't do much over there. It will be good for the patient, it will be good for this panel that we don't get advanced patients. So please, please dilate and have a look at your patients, to look at the disc, detect glaucoma early so we can all be safe. Thank you very much for your kind attention.
Thank you, Dr. Harsh, for giving such practical points about the optic disc assessment. We'll now move to the next speaker, who's Dr. Shibal Bhatia, who will speak about the philosophy of medical management of glaucoma.
Good evening, and sure, I'll just start my screen share, please. Good evening. It's such a pleasure to be here, and I've got 3 of my favorite teachers on the webinar listening in. Oh dear God, let this not go wrong. Just please give me a minute while I get this sorted.
Yes.
And it's going to be really ridiculous because am I on screen share?
Yes, you're on screen share.
Wonderful. So it's going to be a pleasure to be here, of course, and I'm going to be walking you through the relatively more abstract art of glaucoma practice, and all of the experts are going to be talking of the science and the very analog science of what we do for our glaucoma patients. And now, before we go on to that, I will be talking of the fuzzier, more cognitive realm of why we do what we do.
Could you just move to full screen, please? You're on.
I'm not on full screen. Just a
Right.
second.
Put it in presentation mode, doctor.
I thought I did. Is that better?
Yes, that's fine.
Yes, wonderful. Thank you so much. So underlying our glaucoma treatment philosophy, of course, is the best accepted definition of glaucoma. The disease is asymptomatic, it is chronic, it is usually progressing very slowly, and it is a painless optic neuropathy. But we often forget the other bits, the ones that are not in the definition, which actually should be guiding how we look at a glaucoma patient. The diagnosis of glaucoma is more often than not a surprise. Most of our patients are diagnosed when they are visiting for something entirely different. And glaucoma diagnosis, even today, remains scary. Kalamotia is a dreaded word in my part of the world and yours. And the fear of blindness is real and present in the minds of all of the stakeholders, whether it is the doctor, whether it is the patient or the patient's family. So what do we look at when we were to look at the cognitive aspect of glaucoma? What really happens when the diagnosis of glaucoma happens is that there is a sharp drop in the quality of life of the patient, basically because the patient has just been told he has a disease for which there is no cure and one that requires lifelong therapy. Thereafter, both the interventions, which are therapeutic or diagnostic, also affect the quality of life. And once treatment starts, there is a steeper decline in the quality of life than we presumed would happen. This is not just the vision-related quality of life, but also the other part of the quality of life. The vision-related PQLI deteriorates faster than presumed, not just because of the visual field damage, but because of the visual disturbances related to the inevitable ocular surface disorders. Which is why when you look at the target IOP definition, it centers not on the IOP, not on the optic nerve, even though Dr. Harsh walked us through it so beautifully, not on the visual field, which is the final denominator of glaucomatous damage, but against the patient's quality of life. And the consensus there also is that the risks of therapy must be balanced against the risk of disease progression. So even though glaucoma is really not a number game, and if you were to look for least common denominators, because you need to measure what you're doing, we are really working on the metrics that really don't define the target IOP quite so much. We're looking more in terms of intraocular pressure, whether it is peak or fluctuation. We're looking at the visual field and what is happening to the RNFL and the optic nerve. But what we should also be looking at and collating are the quality of life costs of what we are doing, the dropout rates from our treatment paradigm, and the compliance and adherence rates. So today I'm going to see if we can, reach at some kind of a walkthrough to the paradigm of this particular treatment and see if this warpage can be in any way eliminated. So the first thing to remember is that drops will not work if the patients are not using them, regardless of what you choose. And almost any drug that you choose for your patient is going to have a very high early dropout ratio, irrespective of what you decide to do. And it is attributable to the fact that the initial scare that you have of blindness over time will decrease. Also, the patient will kind of get more desensitized to the whole idea of a disease which is chronic and progressive, because really for the longest, they're not going to have any symptoms that are commensurate with it. And your treatment is going to cause a lot of problems for the patient. So the bottom line then is that you start treating the patient and not the IOP. Common sense and all of the guidelines also recommend that we assess the patient as a whole and individualize the patient's the treatment plan to the patient's needs. So we are looking at providing IOP reduction, which is effective, but remember that effective IOP reduction requires the patients to cooperate with you. And two of the most important attributes to patients listening to you are safety and tolerability of the medication that you have chosen for your patient. So when we look at a more holistic approach, we are of course looking at something which really takes care of the intraocular pressure and is easy on the eye, gentle on the patient, but tough on the IOP. So what we are going to look at is whether the efficacy, when Shamira is going to walk you through this actually, efficacy in terms of IOP, both mean and reduction, as well as 24-hour control, leading to a stable visual field function. And when we look at the side effect profile, we're looking at both systemic and ocular tolerability, and consequently patient adherence to the particular treatment plan. In this also, what we often forget is this one person who's central to all of this, the patient, and her or his preferences in terms of what they want done to themselves. So when we're looking at the efficacy measures, we're going to go through these in detail, so I think I can just rush through them. We're looking at percentage IOP lowering in both treatment-naive patients as well as when we are switching treatments. We will look at diurnal fluctuation control, because most of us who do DVs know that that is a bigger cause of glaucomatous damage than just the peak IOP. And when we look at consistent long-term efficacy, we realize that IOP is only a surrogate for visual field and function, and the ultimate aim of any glaucoma therapy is visual field stability. Now, before we move on, I would like you to come back to the first graph that we've looked at. Glaucoma has no symptoms usually until you start treatment. So the more effective central idea of glaucoma treatment is compliance and adherence, tolerability and side effects, costs, both economic and to the quality of life, and ease of use of the drops that you've given. So what you have to understand that since the only modifiable risk factor for progression is IOP, all of our therapeutic efforts are directed towards reducing IOP. But the fact is that what we have to look at is the quality of life cost per millimeters of the IOP. Now, the thing is this a price your patient is happy to pay? And have you discussed it with your patient enough? Tired eyes, sore eyes. I have post-viral dry eye right now, so I know how difficult it is for me to look at the screen for longer than half an hour. And for somebody who has to deal with it lifelong because of what you have done to them is not the easiest. A prescription of a lubricant, I think, is almost an everyday occurrence in any glaucoma clinic right now. And we forget, very importantly, how the dry eyes can impact the eventual clinical outcomes of glaucoma. So remember, more than half of our patients end up having some kind of ocular surface issues, and about 25% of our patients will drop out from glaucoma therapy because of ocular surface disease issues. And if your patients are anything like mine, they will continue to use their lubricants and forget to use their glaucoma medication because that doesn't make them feel very good. So it is important to remember that and recognize that the management of the ocular surface issues may just improve the clinical outcomes in terms of patient quality of life, and eventually also the metrics which are objective metrics of glaucoma treatment. Which brings us to the other biggie that we often forget to talk of when we talk of glaucoma therapy, which is communication. We need to talk to our patients more about the disease, about their fears, about the treatment options that are available, about side effects, about their remedies, about other possibilities, and what it is that we can do to make the treatment less painful. The most important single conversation that you need to have is to teach your patients on how to use these eye drops, because that's the one thing that changes the way glaucoma is managed. If every time you see your glaucoma patient, you can take a minute and ask them to either demonstrate how to use their eye drops or do it yourself and show it to them, it's probably going to modify your glaucoma outcomes more than anything else. No amount of conversation can replace this particular demonstration. Now, it is also important to remember that glaucoma patients invariably struggle to put their eye drops. Whether it is, even if they do remember to use them, and when they remember to use them, most of them are elderly and arthritic fingers, and most of the eye drops, if you've tried putting them yourself, require practice. And as many as 50% are unable to put their drops without assistance, especially the elderly. And this does not depend whether you're using multi-dose or monodose vials, or the gender of the patient, or the duration of disease. This is also an important consideration when you go around asking your patients to put eye drops one after the other, which brings us to the all-important and the most often ignored metric of glaucoma practice: patient centricity and ethics. Now, what is best for the patient, what you think is best for the patient, and what is the best possible route in a given clinical situation. So all of medical ethics hinges on 4 particular points that we need to go through one after the other. The first, of course, is patient autonomy. A glaucoma patient must have the freedom and the agency to make an informed choice, which means you need to have enough time to educate the patient and empower the patient enough to share your decision making, and that there is a value-based customization of your treatment plan. Eventually, this is time well spent because the patient then will adhere to the treatment better if they have shared in the decision making, they understand why they are part of it. Now, beneficence and non-maleficence are words which are not requiring any explanation. Of course, the patient has to be benefited by the therapy for us to choose it. And of course, the collateral damage must be minimal for us to choose a particular therapy. Justice, both equitable and distributive, this is something that has come into sharp focus during the pandemic, because as we are, like Dr. Harsh was also saying, we are stratifying the patients that we call to follow up. And well, that's a clear violation of this one ethical principle, because just because somebody has early glaucoma does not mean they do not require follow-up. But during a pandemic, this particular principle of patient centricity and ethics gets to be in that gray zone where you are supposed to take a call depending on the individual, which is where we are in terms of the ethics and patient centricity. At the end of the day, as in life itself, glaucoma treatment paradigm is all about making intelligent choices guided by education, knowledge, and gestalt. You just have the body of experience that tells you whether something is normal or not, that tells you whether something is working for the particular patient or not, and conversation is key to making these intelligent choices. The decisions that we take just not make us susceptible to COVID, but in this case, this is a decision which will actually make a difference for someone who is going to progress from where they are right now to darkness. And when we took our Hippocratic oath, for some of us not so long ago, and for the others much, much longer, all of us promised that first of all, we will do no harm. And it is important to remember that that continues to remain the guiding principle for glaucoma practice. Glaucoma has no symptoms. All of the glaucoma medication that you will choose will cause symptoms. Target IOP is not so much about eye pressures as it is about quality of life of the patient. Efficacy is extremely important. Tolerance is just as important as efficacy. And both the doctor and the patient have to be happy for a treatment to work. It is something that you have to remember each time when you strive out to think of what you need to do better for your patient. Balance is key. And at every point in time, the risk of therapy has to be more than the risk of progression for you to actually prescribe it. And in case I was given less time than I have been allotted today, or if I was as lazy as I am and did not want to make slides, this last slide would have been absolutely enough to sum up our conversation today. This is from Hutchison's Manual of Clinical Medicine, Clinical Methods. And I think this holds true for glaucoma more than anything else. Do not let the cure of the disease more worse than the disease itself. It is critical to remember that every time we offer the patient a choice where a drug is going to make the patient more miserable than they are at this point, we must have a very good reason to do that. If we will remember this, I think that particularly sums up all of the philosophy behind glaucoma therapy today. Thank you so much for your attention.
Thank you, Shibal, for covering that so elegantly. I'll now ask Dr. Shamira to talk to us about the importance of 24-hour IOP control. Over to you, Shamira. Shamira, can you just unmute yourself?
Hi there, can you hear me?
Yeah, we can hear you. We can see your slides.
Okay, excellent. Thank you very much. Thank you very much, Ronnie, for the kind introduction, and Shibal for doing a fantastic piece on that. I mean, I'm going to have to steal one of your phrases, that glaucoma has no symptoms until we start treatment. I'll obviously reference you for that, but it's a great line, and it's a very important relevance to what I'm going to be talking about here. So I'll be speaking about the importance of 24-hour IOP control. And these are my financial disclosures, some of which are relevant to the talk today. Now, I wanted to go and really talk about how we can look at IOP in a different light. And it's all about quality rather than the actual numbers. And it's a holistic approach, which is something that Shibal was espousing just right now. And we know when we talk about the quality of IOP control, we're not just talking about the mean IOP reduction, but we're talking about other things like the response rate. And we're talking about the long-term IOP control and visual field stability, because that's what's the thing that's important to patients, you know, at the end of the day. And these are the patient-related outcome measures that we should be looking at. Another factor that's come out recently as important is the 24-hour fluctuations, and I'll be going into that into a lot of detail. Shibal was talking to you earlier on about the patient adherence and compliance and persistence, which are all important factors for maintaining that quality of IOP control. Just to give you an idea of what that actually means, there was a little study done by Hughes and colleagues, which looked at the 24-hour monitoring of patients. And they found that when you look at the mean IOP in office and as a 24-hour IOP, you could see there was not much of a change, but there was a slight change in the mean IOP. And when you looked at peak IOPs, you found that actually in office was really not so good as looking at the 24-hour IOPs. And the difference in these values ranged up to 12 millimeters of mercury. In fact, you'd be changing your clinical management in almost 80% of patients if you only knew what the 24-hour IOPs were. So they found that actually in this study that when you looked at the peak IOPs over a 24-hour period, they were actually almost 5 millimeters mercury higher than those in the office IOPs. And the actual peak of these IOPs occurred outside normal office hours in roughly half of those patients. In another study, looking at the importance of looking at home IOPs as well as the office IOPs, these patients had home tonometry measurements done, and you could see that in the first picture here on the left, when you look at the office IOPs, when you compare the rate of progression, when you look at the highest office IOPs and the lowest office IOPs, there's not much difference. So in actual fact, what you're seeing here is actually that it seems like there's no real big deal about measuring the office IOPs. But actually, when you look at the home IOP range, you can find that after the 8-year time point, when you look at the lowest 25% of those with the range of IOPs, you can see that there are 43% not progressing. Whereas when you find in the other group, the ones with the highest 25% of the IOP range, they find that there are 12% that have no further progression. So that you can see that actually it's very important to look at the home IOP ranges. We looked at this diurnal fluctuation in angle closure. It's one of the very few studies that have been done in angle closure. So here we looked at patients over a 24-hour period, and we looked at their range of IOPs, and we looked at the different time points during the day. We found that in PACS normal, the IOPs were much lower than the other groups, and that their fluctuation was not so much. Now, when you looked at the PAC and PACG groups, the mean IOP was higher, but of course, the fluctuation was highest in the PACG group. So of course, it seems to be that the fluctuation leads to glaucoma. Now, how does this happen? Well, it could be from a number of reasons. Firstly, from instantaneous fluctuations in things like the natural changes in IOP secondary to homeostasis. So for example, when you do things like drink a lot of water, you can see a sudden increase in IOP. And this has been purported to be a useful test in some situations at looking at the usefulness of the trabecular meshwork to absorb IOP spikes. When you look at different positions, you can see that in the lying position, we've been susceptible to higher increases in IOP, and the laterality of the position also may play an effect as well. There are these various autoregulatory mechanisms in aqueous hemodynamics that are thought to be behind this phenomenon. And actually, these diurnal spikes and troughs in IOP have been found to be present in normal patients and also glaucoma patients over 24 hours. Now, how do we measure these 24-hour IOPs? Well, this is one example. This is the triggerfish from Sensimed. And what you can see here is a very, very sophisticated device. It's a contact lens sensor for IOP. And you place it on one eye, you close the eye, you pad it up, and there's wires that come out around the side into a battery pack that's placed around the patient's waist. Now, it's very expensive. It's about 500 euros per shot, and it only measures it over 24 hours. But what it gives you is a good measure of what's happening to the pressures inside the eye. Now, it doesn't give you in IOP, it gives you in millivolts equivalent. So that's what you see on the y-axis, and on the x-axis, you can see the time. Now, as you can see in these different groups, the blue, green, and red groups, they're quite different. So the blue group is the healthy group. And compared to the others, you can see that actually, when you look at the fluctuations of IOP, compared to healthy eyes, patients with glaucoma have earlier IOP peaks, higher values in the IOP peaks, and prolonged peaks. And the diurnal IOP profile was poorly correlated with nocturnal IOP profile. Now, when you look at this other study, this was a study that was done on eyes that have had about 8 visual field tests done. And they looked at the IOP during 3-hour periods from 9 a.m. All the way through to 9 p.m., 24-hour period. And when they looked at this, they found that actually they were measuring the IOPs during the daytime with the normal pneumatometer, so with normal GAT, and during the nighttime supine with a pneumatometer. And what they found was that actually the worst visual field was associated with higher 24-hour IOP peaks and also greater fluctuation as defined by the range of IOP values. So again, in this group that were NTG patients, we're finding that the peaks make a difference and the fluctuation makes a difference. And this actually is borne out in our clinical practice. We find that fluctuation is more important in those patients where there are lower IOPs. Where you've got POAGs and PACGs, for example, with very, very high IOPs, the fluctuation is not so important. But in the lower IOPs, then the fluctuation becomes a much more important factor. In another study that looked at 24-hour IOP fluctuations and glaucoma progression in 240 eyes of 120 patients, you could see that when the patient was awake, the key factor was the number of large IOP peaks, and that led to greater visual field progression. However, when the patient was asleep, you found that the key factor was the mean IOP peak ratio. Now, what that means is that a high peak ratio is where somebody has a large peak that occur at a higher speed, in other words, a higher acceleration. And this is well known to be a cause of greater damage on the biomechanic level to the optic nerve head. And this is what causes the progression. Now, moving on, when you look at the cases of these 24-hour IOP fluctuations and glaucoma progression, the other factor here that we're looking at is short-term IOP fluctuation. And these have caused not only an increase in the visual field defects, but also increase in the cup area, so a structural defect on optic nerve imaging. Now, how does this impact us on a practical level? Of course, we know that some of these tests are not really very practical unless you've got a lot of facilities and the wherewithal to conduct these quite intricate testing, and of course expensive as well. So I would suggest that, whenever you have the opportunity, do some kind of phasing, whatever means necessary you can. Ideally, it would be with a appellation tonometry, but of course, if the only method available to you is with a tonopen or with an EPUF, that is also still useful, because we look at things like the 24-hour range of IOPs and the difference between both eyes as well. In this study, this was done by Professor Constas, who is a an expert at doing these crossover studies. He did a prospective observer masked crossover study looking at patients with open-angle glaucoma, and they were randomized to receive either preservative-free tafloprost or preserved latanoprost. Now, what they found was that there were two important findings from the study. Number one, the tafloprost demonstrated a greater mean 24 IOP reduction against latanoprost. So in other words, the mean was lower in the tafloprost compared to the latanoprost. And secondarily, they also found the fluctuation was also more limited in the tafloprost group. So this is also an extra benefit as well. The primary endpoint was the mean 24 IOP, but the secondary endpoint was the fluctuation. So again, you can see how tafloprost in this study shows a beneficial effect against latanoprost. So to summarize, I'll say that IOP fluctuation is really underused and underestimated, and it should be utilized more by us, especially in the cases of normal tension glaucoma. We should use the peak IOPs from phasing and initial diagnosis to guide our treatment, to look at what kind of target IOPs are strive for in the longer term future. But of course, that's a talk for another day. Now, monitoring, as we've seen here, is difficult at the moment, is expensive and cumbersome. But of course, this area is set to grow. And imagine the differential change in our management when we have all this extra information. I'm sure it's a big growth area for the future. So thank you very much for asking me to speak today. And I hope this would hopefully change your management and make you understand about the differences that glaucoma specialists look at IOP fluctuations and peak values and mean values compared to the other ophthalmologists. And hopefully you can incorporate this in your practice very soon. Thank you very much.
Thank you, Shamira, for covering that so simply and making things very clear. Before we move to the next speaker, we have a small video from our sponsors. And Sunil, can you play the video, please? Sunil, can we play the video? Thank you. Thank you. Now over to you, Satyan. So Satyan, Dr. Satyan will be talking about hyperemia, possibly the commonest side effect that we get with any glaucoma medication.
Thank you, Ronnie. And I would like to thank Sibel and Shamira for covering my topic as well. So we all know that the hyperemia is a menace, especially with the anti-glaucoma medications or any chronic therapies in the ocular surface definitely causes more damage. So we know this kind of eyes, it's not uncommon to see in our glaucoma practice. So most of the glaucoma medications, or at least many of the glaucoma medications, does cause this problem. Though it has its own effects, therapeutic effects, but we need to understand the side effects. Especially, there are many published articles on the anti-glaucoma medications and on the ocular surface, how much it can really damage the ocular surface. So just look at the definition of hyperemia. It is increase of blood flow, that is engorgement of the conjunctival blood vessels is the definition. So what is the actual problem that we have? One is the cosmetic problem, that is the ugly looking eyes, which probably leads to non-compliance in many of our patients. And of course, there is an increased overall cost in patients who are treated with not only the PGAs, whatever the medications which causes the more adverse events. There is always an increased cost. And of course, what is that which really bothers me is the compromised outcome on the filtration surgeries, that is the trabeculectomy. So looking at the hyperemia evaluation, we have definitely some limitations. There are conflicting results and the bias. So just to look at, one is the color based. So overall redness we look at and then say how much is it mild, moderate, or severe. The other way to look at is the vessel morphology, means that is the area occupied by the vessels, the number of vessels, the diameter, and the tortuosity, and etc. by using some of the algorithms by various people. So this is the hyperemia severity grading scale. There are multiple severity grading scales are available. You can see that VBR, that is a validated bulbar redness scale, IER, IFRAN, and then McManus, and of course we have something from the Japanese as well, that is the Ocular Allergy Society grading system as well. But the problem with all this is the high intra and the inter-observer variations. So there is a bias in this actually. So what is the best way is to go is the hyperemia analysis software, which looks at the proportion of the blood vessels. This is the software which is available, and currently it is being mostly used for the research purpose. But this is one of the best softwares that you can use it to see the hyperemia grading. It is much more convenient, more accurate, and then it has a very, very less bias. So just to show between the two systems, one is the clinical grade, and you can see on the right hand side is your pixel coverage value. So this is the software based, which is much more accurate. So how do we really evaluate the hyperemia in our practice is much more simpler, looking at the conjunctiva, looking at the blood vessels before and after starting. This is kind of a mild. Then we call this as a kind of a moderate congestion or moderate hyperemia. Then of course, obviously we know that this is a severe hyperemia. So these kind of patients obviously is not going to use the medications unless there is a very advanced glaucoma and then you are forcing them to use. Even these people might be just missing a few of the drops. So we have seen why we are concerned about it. Of course, all the three problems which I've already mentioned. One is the cosmetic problem. Then there is overall increase in the cost. And of course, the compromised surgical outcomes. So when you're looking at the side effects of these medications, as Dr. Sibal was showing, the side effects of the glaucoma medications could be as high as 42%. But when you're looking at the hyperemia alone, about 27.4% of the patients were kind of discontinued their anti-glaucoma medications, which we all know what is going to happen. The discontinuation is going to cause uncontrolled intraocular pressures with the progression of the disease. So the long-term treatment with the anti-glaucoma medications, how does this cause the surgical outcomes altered? We know that we have enough of medications like beta blockers, CAIs, alpha agonist, and so on. But then not a single medication without any adverse event. Almost all the medications do have some amount of adverse events. Just looking at the beta blocker versus prostaglandin under control, the beta blocker seems to have a little less hyperemia in comparison to the prostaglandins. Obviously, we all know that. In clinical practice, we all have seen that. Looking at the Indian market, the tafluprost is a new entrant, and all the other three molecules were already there. So looking at this table, you can obviously see that the tafluprost has probably the lowest amongst all the prostaglandins in inducing the hyperemia. So you can see that when you're looking at the other three PG analogs, which are already there, the bimatoprost seems to be having a slightly higher than the travoprost, and the lowest being the latanoprost. When you're looking at the combination with the latanoprost, it is not that you don't have any problem with the latanoprost combinations. Of course, you can see that the lowest hyperemia incidence in a combination seems to be with the latanoprost brinzolamide comparison. Though this molecule is not available, the ripasudil, omidipinag, whatever I tried my level best to pronounce this, but somehow I'm not still getting this in my mouth. So you can see that obviously the ripasudil still has the higher incidence of hyperemia. So what really happens when you use the anti-glaucoma medications on the conjunctival surface? One is it induces the conjunctival inflammation, and also it alters the cell structure and the cell counts. So what is that we really look at when you're looking at these specimens? So we have to look at the cellularity, we have to look at the cell-to-cell junction, nuclear cytoplasmic ratio, how much it is altered, and we have to look at the chromatin levels, raw blood cell distribution, how much of the keratinization has happened, and also we need to look at the inflammatory cells presence. If you get a score of more than 4 to 6, then obviously the conjunctival cytology is completely kind of altered. These patients, we can kind of say that these are the patients going for the failure of surgery. So these are normal cells, you can see, and you can see how abnormal this has become. The conjunctival cytological changes, especially the 100% change in the nuclear cytoplasmic ratio with the inflammatory mediators being there. So this is a patient who has been done, who has gone through the surgical procedures, multiple procedures. You can see there are 2 bleb areas, and you can see the hyperemia as well, because this patient is on PGs and also other anti-glaucoma medications. So it's not very comfortable for the patient. So looking at the hyperemia associated costs on the medication changes. So these are research methodology. This is one of the big studies, like they've included about 8,743 patients who are on the PGM monotherapy. And these are physician-reported rates of hyperemia were obtained from the chart reviews of about 300 patients. So if you just look at this, the hyperemia-free patients versus the discontinued initial therapy due to hyperemia patients, there is a significant increase in the cost. That could be because of stopping one PG to another PG, change over to another PG, calling them for follow-up, then treating them for their hyperemia. So there is an additional cost which is involved in this. So there is an add-on cost for this. So the hyperemia results in, there is an increase in the overall cost for the patient. So looking at all the 4 PGs, we always think about hyperemia. What is the reason? Is it the molecule as such causing the effect, or is it the preservative? If you look at the tafluprost being one of the PGs, it has the lowest concentration of the molecule and also the lowest concentration on the BAK. And so that's the reason, one of the reasons why the incidence of hyperemia in tafluprost is much lower in comparison to all the other PGs. You can see in this slide as well, all the 4 PGs are given, and I can see the lowest incidence being with the tafluprost. So just to summarize, we all know that we all have to start on anti-glaucoma medications, but effectiveness of IOP lowering is not enough, but we need to concentrate more on the quality of life, like what Sibal was mentioning earlier. and its associated side effects, how much it can alter the outcomes like a surgical outcomes or the ocular disease, ocular surface changes, how much it can cause. We need to think overall for the patient's quality of life. So I would like to acknowledge Mr. Gyan and Mrs. Rajashree for helping me in preparing my slide. And I would like to appreciate all your attendance. Before you have the redness in your eyes, I would like to sign off. Thank you so much.
Thank you, Satyan. So before we move to the last session, I'd just like to inform the participants that you can ask questions in the chat box or on whichever platform you're in, and we will take them up after the last speaker. So the last speaker today is Dr. Chandrima Paul, who's going to talk to us about the Indian experience with tafloprost. The drug came to us relatively recently, so it'll be nice to see what experience we have with it. Over to you, Dr. Chandrima.
Thank you very much, Dr. Ronnie. And as I share my screen, I'd like to thank AIOS and Santon, Mr. Gyan especially, for this invite. It's wonderful to be here with a galaxy of glaucoma experts. And in the next few minutes, I would take you through tafloprost, my experience in the Indian eyes. So we've heard from my previous speakers that current challenges in glaucoma management, very well put forward by Dr. Shibal, is a challenge, and barriers to health care uptake, like glaucoma is often remains undiagnosed, is difficult to detect in early stages, IOP being normal, and there's a high dropout rate, and there's a lack of the disease awareness in the population. The efficacy aspects of IOP measurements. IOP is a highly individual and dynamic method. IOP changes from baseline, the mean IOP change. Baseline IOP is always what we are looking at, but sometimes we cannot do it because the patient doesn't have records and we haven't seen the patient first, already on anti-glaucoma drugs. 24-hour IOP fluctuation monitoring, that's a challenge, which Dr. Samira also spoke about, and the responder rate to treatment, well, that needs to be seen, and persistent long-term IOP reduction is always a challenge. So what to check in a busy practice, what is idle and what is practical, let us see. So the efficacy of one-time IOP recording is often misleading, can be a poor indicator for diagnosis and treatment, and poor surrogate of the entire IOP profile of a patient with glaucoma. So a drug with proven 24-hour IOP control is actually what we are looking for. And the adverse effects, commonest, they have already been spoken about, so I don't need to go through them in detail. I just would like to share this analysis of 36 randomized controlled trials that included 17,511 patients, which identified that adverse effects as the most common cause of withdrawals. That's 46% of withdrawals compared to 10% of withdrawals for inadequate intraocular pressure control. So survey results confirm that the impact of adverse effects on adherence in real life as well as in clinical trials. So the high dropout rate in glaucoma treatment actually is seen with almost all glaucoma medications, as you see from that graph out there. All of them actually have a dropout rate, and as very well stressed by my previous speakers, it's like quoting Dr. Shibal once again, is that glaucoma doesn't produce symptoms until you actually start treatment. How true that sentence is actually. So from there, we move on to the menace of hyperemia. Dr. Setan did a wonderful job of getting across to us that hyperemia, how annoying it can be. And 27.4% of patients with hyperemia were discontinued from their medication. So patient adherence, continuation of treatment, and IOP control all seem to pose a challenge. Why so many dropouts? Factors on the treatment provider side. We have installation failures. We can have adverse events profiles or without a good IOP control, difficulty with medication schedule, difficulty with drop administration, and of course, in our country, cost is always a huge factor. But we also have factors on the patient side, like low awareness of glaucoma. They think, what for am I using these drops? I don't have anything. And then, of course, they forgetfulness. So the criteria of a novel PGA, properties of the idle anti-glaucoma molecule that we look for, the unique drug design of tafloprost, the landmark studies on saflotin, clinical efficacy of tafloprost, and safety and tolerability is very important. So we did find it does have an effective IOP control, quick IOP lowering effect, better circadian control over the IOP fluctuations, higher responder rate, and consistent long-term IOP lowering effect. Tolerable and safety profile, it has a low overall incidence of adverse drug reaction, preservative-free or optimized preservative content, but now we do have the preservative-free version of it, and associated with stable visual fields, improves orbital microcirculation. I'm still to actually see that, but the top story here this evening is actually the unique drug design of tafluprost, which is the fluorine atoms bestow a more potent affinity for the prostanoid FP receptor than that exhibited by the other PG derivatives. So if you look there, it's like the 15th position of that is actually substituted by the difluorine atoms out here, which is different from all the other prostaglandin analogs. And if you look at that, what it actually does is that the electron attraction, high receptor interaction, high FP affinity, strong IOP lowering effect, strong and durable stability, storage at room temperature, and lipophilicity, improved PK, and prolonged and improved ocular blood flow. So with that, we move on to the study which was done where they actually found that the difluoroatoms increased tafluprost binding capabilities over the other PGAs, as you see out there. And this is actually a unique feature to tafluprost where it actually activates signaling and this collagen matrix by releasing the metalloproteinase. It causes this cleaved matrix, and which actually causes outflow in the trabecular meshwork as well, secondary to the uveoscleral outflow. So the inference of the story is that my experience, well, we have been using the drug for from the time it was launched in India, that's somewhere I think in November, and then case one is initiation of tafluprost in treatment-naive patients. So this was a 55-year-old female patient, a housewife, had not had a complete eye examination for several years. She was diagnosed with primary open-angle glaucoma in both eyes, and the baseline IOP, right eye was 26 and left eye was 24 millimeters of mercury. She had early cataract in the left eye and systemic hypertension for 7 years. I told you that she's a treatment-naive patient, and we decided to start PGA. So decision made to start the treatment with saflotin preserved with buck. That's when we did not have the preservative-free version. There was significant IOP reduction observed in both eyes at week 4 and 12, no incidence of observed side effects. And that's she started with 26 and 24, and then ultimately at the end of 12 weeks, it was 19 and 18. This is case 2, switch from latanoprost to tafluprost. So this was a 58-year-old male patient, a teacher in a government school, diagnosed with, again, primary open-angle glaucoma in both eyes since 5 years, no family history of glaucoma, early cataractus changes, systemic hypertension for 6 years. The patient was diagnosed with primary open-angle glaucoma 5 years back and prescribed latanoprost. So decided to switch to tafluprost due to non-availability of the current therapy. Latanoprost was not available for quite some time. So the decision was made to switch, and by then we had the saflotin, and IOP was further decreased at week 4 and week 12. At week 4, there was mild conjunctival injection and observed in the right eye. At week 12, it was clear, and the IOP was 16 at 12 weeks in both the eyes. This is case 3, switch from tavaprost to tafluprost. So 55-year-old male patient, avid reader, diagnosis of primary open-angle glaucoma in both eyes since 3 years. Nothing significant in the systemic conditions. Initial treatment, patient was on treatment with travoprost since last 3 years and was also using Cysteine Ultra, that's the tear substitute with polyquad as the preservative. And we decided to switch to tafluprost preserved with buck. And the decision was made to switch to saflotin. So the patient got further IOP reduction at week 4 and week 12. If you look at that, it came down to 20 and 18. And there was no incident of observed side effects. And mind you, we had stopped the Cysteine Ultra. This is case 4, switch from tafluprost to preservative-free tafluprost. So this was a 55-year-old working female patient was again diagnosed with primary open-angle glaucoma, had dry eye and mild ocular hyperemia. Patient was on treatment with tafloprost with bark since last 1 month. So once we had the bark-free tafloprost, we switched her over to that. And the preservative-free tafloprost maintained IOP at the same level. And if you look at that, the conjunctival redness, the ocular hyperemia score, it did come down drastically, and IOP also was maintained. So with that, I move on to case 5, that is 42-year-old female, a patient, a software executive from Nagaland, northeastern India, has not had a complete eye examination for several years. So a gonioscopy showed that she had Sheffer's grade 1 and 2 over 280 degrees in both eyes. Diagnosis of primary angle closure suspect in both eyes with baseline IOPs of 26 and 28 millimeters of mercury. She complained of frequent headaches at the end of the day, and her mother did have primary angle closure glaucoma. So prophylactic YAG PI was done in both the eyes, and she was kept a week on dexamethasone and dorzolamide drops. Gonioscopy repeated after a week, and with the patent PIs, the decision was made to switch to saflotin, and significant IOP reduction was observed in both the eyes at week 4 and week 12, and there was no incidence of any observed side effects. So with that, we actually inferred that the IOP was significantly reduced by 4.2 plus minus 4 millimeters of mercury in the new monotherapy group, 1.9 plus minus 3.6 millimeter of mercury in switching from prior treatment, and 3.8 plus minus 4.6 millimeters of mercury in the add-on therapy group. IOP was significantly reduced in patients who switched from latanoprost, travoprost, and other glaucoma medications, and the overall reduction was about 3.8 plus minus 4.4 millimeters of mercury. There you see in patients who were first started on tafloprost with a 24 millimeter mean IOP. The IOP did come down at 4 to 6 weeks to 16, and then it maintained at 12. That's almost 32% reduction in IOP. So more than 30% IOP lowering in treatment with new patients at 12 weeks. And that actually is tafloprost versus latanoprost at 6 weeks, achievement of IOP reduction. So here as well, if you look at that, we actually saw 80.8% of cases achieve 20% or more IOP reduction by tafloprost as compared to latanoprost, which achieved 71.6%. The safety profile, saflotin administration resulted in 39 eyes which had adverse reaction in 21 patients out of the 295 patients who we could actually follow up, considering all the lockdown and everything that we had. And the percentage of patients with adverse drug reaction was about 7.1%. The most frequent adverse drug reactions were hyperemia. We did that calculation on the clinical grading of hyperemia, and blepharal pigmentation and OSD. We generally saw the Shermas and the TBUT timing, and that's how we came to that. That's 2.8% actually. And so the laurels that I would attribute to the molecule are excellent receptor affinity and selectivity, proven IOP lowering efficacy comparable to other prostaglandin analogs, additional IOP reduction in glaucoma patients who have been on other medications, and superior safety and tolerability. We do have the bark-free variety now. And that is it. Thank you for your attention.
Thank you, Dr. Chandrima, for showing us how it works in different situations and overall how effective it is. We have some questions from the audience, and I'd like to ask them now. Yeah, Dr. Harsh, the first few questions are for you. The first question is, how do you differentiate glaucomatous and non-glaucomatous cupping in advanced glaucoma when the intraocular pressure is normal, when vision is low and fields are not possible, and the OCT shows RNFL thinning?
That's very interesting. We already said that in advanced glaucoma, it is practically impossible to use structural damage. So neither the OCT nor the disc will give you the clear idea about whether it is glaucomatous or not. And I showed you that myopic disc, which is really very difficult. So please, in all patients, always go for the whole thing. So you have to do, like Shamira really rightly pointed out, do a 24-hour diurnal variation. You may find a peak somewhere else where you are missing it. That is first. Secondly, you have to check for the family history. You have to check whether there's any nighttime snoring, etc., which will give you that there's another problem over there which can cause glaucoma. Look for splinter hemorrhages, because that is one clear thing that could lead you to shift your balance towards glaucoma. And if the vision is so low, you have to look why the vision is low. That means there are some retinal changes which are occurring. And yes, I agree, in those situations it may be very, very difficult to really figure out, but you have to take the overall picture.
So, and something also in terms of how rapidly the vision deteriorated can sometimes give a clue, because
Right.
we don't see very rapid deterioration with in glaucoma
changes. Yeah.
So we have another question from Dr. Smita Nambiar. This again for you, sir. Would you ask for an MRI scan in all cases of temporal pallor of the disc?
Like I told you, initially you will have to do a good gonioscopy, because a large number of patients are angle closure, and it will many times that disc look like a temporal pallor kind of a thing. But yes, if there's a bilateral temporal pallor, in so many times these patients have been treated for glaucoma, and then when you do an MRI, if the patient is poor, start with doing a X-ray skull lateral, which can be done in 200 or 100 rupees only. And if still you are confused, you do a visual field test first. The field will guide you. If there's a vertical cutoff somewhere, then definitely you would like to do an MRI.
Thank you. I'll switch to you, Shamira, now. That there's one question which is basically, will blinking cause a greater variation in the intraocular pressure?
Yes, actually, I mean, we did a study here in Singapore. Actually, we looked at just that kind of thing. We looked at the extremes of blinking. So we looked at patients with hemifacial spasm. Okay, so these are people who have a unilateral cause of a really forced closure of the eye. And we did not find any association with glaucoma. So that was quite interesting in itself. And then we did another study on that group of patients where we looked at the water drinking test to see if there was any inability for them to absorb pressure rises. And remember, when you blink the eye, especially forcibly, it can go up, to 50, 60. And we found that actually in those eyes, there was a little difference in terms of their ability to absorb pressure rises. So yes, blinking does cause spikes in IOP. In the normal level, it doesn't really do anything much, but on the forced closure for things like hemifacial spasm, it does mean a big deal.
It also does impact intraocular pressure measurements when you're taking a measurement.
Yeah, yes, of course, as well. Yes, that's right. Yeah. So you've got to make sure that, you're keeping the eyelids open, but not pressing on the eye at all, because that can also raise the IOP. Yes. We frequently see patients such as children who are blinking a lot, and there is artificially raised IOP. So we often write down, this is IOP taken whilst the patient was blinking, to give us an idea that this was artificially high.
There's also a question on how would you do a diurnal variation in your patients? And do you do 24-hour diurnals routinely in Singapore?
So we don't do 24. We do from 8 o'clock in the morning to 6 o'clock p.m. And that's our sort of standard range. I know in other places where it's more feasible to admit the patients, then they can do 24-hour IOPs, etc. But I think for our normal phasing, 8 a.m. to 6 p.m., it gives us a lot of information still.
Yeah. So is there any other alternative if the patient can't sit through the entire day and get the pressures tested? I mean, it is open to anybody. Yes, Dr.
I think the trick is to do a split diurnal variation, as Asrani was telling me once, that you call them at different point of times, never really admit them, because once you admit them, their mindset is entirely different. So call them at various point times, and if your fellow is there, then it is great to be. And if you really want to do a night one, then please, if sometimes it does happen that, especially in cases of normal tension glaucoma, like it was being pointed out, and then again in ocular hypertension, you really want to know what is the peak. In those situations, you may have to send it to some hospital which actually does this kind of a work. So Ronnie, do you mind if I ask Shamira something?
Please go ahead.
Yeah. So Dr. Pereira, actually you said in one of the slides that if you do a total diurnal variation, almost 80% of your patients, you will change your treatment. So does this mean that 80% of our patients we are treating wrongly?
Yes, I mean, it's an interesting question, isn't it? I mean, we frequently diagnose patients with NTG, and if only we measure them for a little bit longer, 30% of them would be diagnosed as POAG. Remember, we're only looking at a single pressure in a lot of cases and making a diagnosis. Okay, so I think
80% you are saying you'll change your management.
So, I mean, I'm saying that when you have this extra information, it is very, very useful. And I think in the future, these home monitoring and IOP sensors is only surely to grow. So I think any useful information is useful to me. But of course, I think that 80% of information there is probably a bit of an overestimate, I would say.
So, but Shamira, it could over or under treatment. I mean, if you previously thought they were NTG, and you do a diurnal and you find they are spiking, you might be happy with the pressure control in that situation.
Well, I think we would be changing their diagnosis firstly to POAG, and then we'd have a better idea of, for example, what's their peak IOP and what kind of target IOP we would aim for. Secondarily, we would be able to have an idea of, the differential between one eye and the other eye as well, that we wouldn't get otherwise if we have just like a single reading.
That's interesting. Shibal, I am going to ask you this question because I know you've worked with the contact lens too. So somebody has asked what the device is called. It's called the Triggerfish. And what is the cost in India?
Not available in India from what I know. I can't buy it off it. But when it was launched, it was 1,000 euros. Now it's available at 500 euros. We don't have DCGI clearance for commercial sales yet. I wanted to go back to the question that Shamira took and then Dr. Harsh took over after that. The water drinking test is a beautiful surrogate for the DV, and I believe in it with all my heart. I know most of the panel doesn't, but it is the cheapest DV you can do. If you just have somebody drink, as long as they don't have contraindications to a fluid overload, 10 ml per kg body weight of water, and check whatever device you have. It can be a non-contact tonometer because you're looking at fluctuation and not at absolute values. See every 15 minutes for an hour how the pressure peaks go up. It correlates beautifully with what happens at night, number one. Number two, it tells you how quickly the body recovers, so which gives you an index of the outflow facility. So I think the water drinking test is extremely underutilized in our clinical practice. And I have for now, in spite of having worked with both the Triggerfish and having facilities for DV and a sleep lab in my hospital, I have almost migrated to water drinking test. It's cheap, it's easy, it's quick. And I don't have access to fellows, so I can't ask them to stay through the night. And I refuse to give up my quality of life and stay up through the night with the patient. And it just makes a lot more sense to try the water drinking test. It's not a diagnostic tool. So remember, when we were taught of the water drinking test, at least when I was a postgraduate or a resident, was that it was a tool to diagnose glaucoma. We are not talking of it as a diagnostic tool, but as a tool merely to estimate and approximate the peaks and fluctuations. Completely and totally believe in it. The contact lens sensor, on the other hand, is more of an experimental tool for now. It's a research tool. Bringing it to clinical practice is expensive and cumbersome. I mean, I've used it now for almost 10 years. And
it's interesting that you say that, Shibal, about the water drinking, because we actually had the opposite experience. We found it didn't correlate with our peaks in our study, which is hopefully soon to be published. I'm going to switch gears to the hyperemia now. And Dr. Chandrima, could you tell me what you tell your patients before you start them on the medication? Because hyperemia is fairly common. Do you tell them to expect it? How long would you wait before you decide that it's a problem?
Yes, so routinely, actually, I do tell them, and the counselor again actually repeats what I've told, that once you start this medication, it's at night, so you would get some amount of redness in your eyes for about a week or so, but the redness would go off in a week's time, and you don't worry about it. And that's the reason we ask you to put it at night initially, and then you stick to the timing and go on. That's how we actually counsel them, saying that the hyperemia would be there, and that's normal. Don't worry. But even then we do get phone calls like, saying that it's red and what should I do? that kind of.
Have you had anybody with intractable hyperemia where you've had to stop the medication?
Yeah, we had to. Yeah, we had to. And then it's quite a challenge because it's an expensive medication, and they come and say, what do I do with this? Do I throw it, or can you use it on somebody else? So yes, we had to stop.
Yeah, and I think that's a story with all the prostaglandins. You do get the rare patient who's very, very intolerant to this. So when you look at tafloprost, I mean, Satyan, you had shown that the hyperemia rates are lowest with tafloprost. So is there any reason for that? To say anything in the composition which causes lower?
Yeah, I think if you have just noticed Dr. Chandrima's presentation about the molecule, the percentage of the drug, and also the preservative which they use, though it is a BAK, it is a different kind of a BAK what they use. It's been, I think it is only from Santon they have this BAK constitution. So both helps in reducing the hyperemia in tafloprost in comparison to the other PGAs.
Yeah. So even though the concentration of BAK is similar, the proportion of BAK-C is much higher. And that is, I think, a little more conjunctiva friendly than the BAK mix, which is used otherwise. So we do have a few more questions over here, and one of them is, so in terms of your, I mean, I think none of us, maybe with the exception of Shibal, has access to a 24-hour facility for diurnal IOP measurements. So when you do your diurnals in your clinic, how often do you check the pressures? Is it every hour? Is it every couple of hours, 1.5 hours? How do you do it?
Probably we'll start with Shamira and then one by one.
Okay, so in our clinic, we will usually measure every hour from 8 o'clock in the morning to 6 o'clock at night. And this is done so we have a range of IOPs on each eye, and we will look at not just the peaks and the troughs, but also the differences between the eyes at different time points as well.
How often you check, Shamira?
Every hour.
Every hour, okay.
The more measurements, the better. That's the way I look at this, is that it's all information, and the more information you have, the better it is.
So that's, Shamira, is applanation tonometry every hour?
So it depends. So we do applanation as much as we can, and then also we will do air puff, whichever is available. Just a mixture.
So we tend to do it every 2 hours with applanation, and we try to make sure it's the same instrument and the same person taking the IOPs.
Yeah, usually I also go with every 2 hours, but if the patient wants to go home, then probably we'll look at around 9 o'clock, around 12, 12:30, and then 4 o'clock. These are the 4 peak hours which we need to look at, depending upon some of the patients, they want to go early. So 8, 12, and kind of 4 o'clock.
Yeah. Yes, Dr. Chandrima, you
generally do it 2 hours. We start in the morning at 8 and finish off by 6. But then since the main hospital is in the central area where there are a lot of offices, we also have this thing of telling the patient that if you want to go back to your office, then you can come back and do it. And that's when we call that the random office IOP. So the patient comes back, say, every 3 hours or so, and we do the IOP. But of course, definitely with the same applanation and by the same examiner.
Okay. So Dr. Harsh, I have a question for you from Dr. Devdutt Thomas. He says a patient had a suspicious disc with normal fields and borderline pressures 5 years ago. Lost to follow-up. He presented recently with a cataract, was found to have total loss of the inferior rim with a superior altitudinal loss with normal IOP. How often is this presentation encountered? Would you consider NAION as a possibility, or would you attribute this to progressive glaucoma?
Yeah, definitely. If there's the type of field you're describing, yes, it could be both the things actually. But yes, NAION cannot be ruled out at all. And especially if it is an elderly patient, then definitely, probably you will have to look at that aspect as well. But first you'll get the cataract out and look at the diurnal variation, see how the pressures are. If it is on the higher side, maybe you'll just do a combined surgery there.
Yeah, so I think this again brings up the important issue of taking a good look at the disc both before and after the cataract surgery, because sometimes you do the cataract surgery and then you realize that the disc is blown. You've not done anybody any favors.
Yeah, actually, the patients are very, very angry many a times. And so often, that's what I said, so often we get patients who have been going to that cataract surgeon repeatedly, and yet that has been missed. So I think that is really a tragedy.
Yes, in fact, when in our population-based study, 7% of pseudophakics were actually glaucomatous. Because they're the same population which gets glaucoma. When they get older, they are anyway exposed to the same risks as anybody else. I'm sure, Dr. Chandrima, did you also have a similar experience?
We had an absolute similar experience. And the saddest part is that I think for comprehensive ophthalmologists or cataract surgeons, basically only high IOP is primary open angle glaucoma. Nothing else actually contributes to open angle glaucoma. So they do not actually have a look at the disc at all. So that's very common actually. And we had almost the same percentage also in the study. Yeah.
So I think we are reaching the end of our allotted time, and I thank all the speakers for both sticking to time and giving such thought-provoking presentations and participating so actively in the discussion. And maybe at the end, I'd just like to make a few comments. And one is that let's not rely on a single intraocular pressure measurement, both to start treatment or to detect disease. Make sure to take a look at the disc like Dr. Harsh pointed out. Keep in mind that once you start therapy, both quality of both IOP measurement, quality of IOP control, and quality of life of the patient, including both side effects, cost of medication, and the headaches associated with glaucoma are important. And at the very end, I'd just like one quick round of everybody answering. What do you tell your patient the first time they've been detected to have glaucoma? Dr. Harsh, we'll start with you.
Okay, I think it's very, very important what that Ronnie asked is, I tell everybody wherever I take the lecture, please, for the first time glaucoma patients, sit down with them for 5 to 10 minutes. I'm sorry to say so many glaucomas that come to me have never been told how to put the drops like Shibal was showing, how to do a punctal occlusion. But more important than them, most of them don't have a clue that we have to come back in 6 months and 9 months to get a visual field done every 2 months. So I sit with them, I tell them, if you come to me every 2 months for a pressure check or the nearby doctor for a pressure check, come to me at 9 months or 1 year or whatever we have decided for field tests. And this is the way to put the drops. And if you don't put the drops, this is the situation that will happen. But if you put the drops, I can promise you that you'll be absolutely all right. I think that is critical, and it is very critical. What Ramakrishna taught me was that tell them how by your hands, how to put the drop and how to do the punctal occlusion. I think that is very, very important.
Dr. Shibal?
Yeah, putting eye drops. I think that's the one thing that I do. Talk about follow-up, same as Dr. Harsh, but my consults are really long. I see less than 8 patients in a day, so I have the liberty to have a really long consult. So it starts off with, and I usually also, when I start eye drops, counsel about redness, so I don't get the phone calls that Dr. Chandrima does. I invariably end up telling them that, if it's an allergic reaction, your eye is going to be bloodshot, there's going to be tearing, there's going to be a little swelling. But if your eye is just a little pink, take it easy for the night. Let's wait for a few days and see how it goes. And it is not an allergic reaction unless it's livid. So that means that I get a better night's sleep. And I don't know if you saw the boys go through. I have a room full of teenagers right now in the house. The last thing I need is people calling me when I'm off duty. So that's critical. It's also important to communicate 2 things in balance. One is the fact that this disease is potentially blinding, and also that a diagnosis of glaucoma does not mean blindness. And it's a very tightrope walk, which I have struggled with through my career. I've been now independently practicing for almost a decade. It is something that I have failed to find a balance on. How do I not scare them and yet scare them enough to use their medication, which is making their life miserable, which costs a lot of money, which makes their eyes red, which means half a dozen of them come back and say, everyone asked me at work if I was drunk, which is not a pleasant conversation to have. But this is a tightrope walk that I'm still learning to negotiate. But how to put eye drops and asking them to show me how they put their eye drops is something I do at each follow-up. And I do have the luxury of time, like I said, unlike more busy practitioners. So that's something I can do at each visit.
Thank you, Shibal. Shamira, do you do anything differently in Singapore?
No, I think I want to echo what they've said already. I think it's important to remain positive. I say to them, don't worry about this. I will do the worrying about this. I'm responsible for you.
Thank you. Satyan, how do you counsel them?
I would probably first develop the confidence in the patient, because most of them, the moment you say it is incurable or you go blind, all these things, they will be really kind of threatening them. So my first focus is on how much I can develop the confidence in the patient so that they come back to us. That's the first priority I have. Not every investigation I do and the first time when I'm seeing them, because I always have the fear of every patient is different, right? So some of them may be having a is it going to be too expensive for me to do the test? So all those things will come in the mind. So first priority is to develop confidence, and then asking them to use the drops regularly. And then when they come back for the follow-up, I just tell them to bring their either children or their siblings, so that we can screen the family. That's what I concentrate on.
Dr. Chandrima,
Yeah, so that's one patient who I speak to and give the chair time. And I have a picture in my clinic of the disc, a glaucomatous disc, and which looks like the red sun setting. And below that is written, we cannot change your yesterdays, but we can change your tomorrows. So I tell the patient particularly that what has happened to you, what is gone, we cannot bring back, but what remains, it will remain here if you follow the advice and if you put your drops and if you come for regular visits, basically. That's it.
Thank you. I think we have covered what we normally tell a patient, and I think that communication is really, really important. Once again, I'd like to thank all the speakers and wish you all a good evening. Thank you very much. I also like to thank AIS and Santan.
Thank you. Thank you, Ronnie.
So well.
Thank you all. Thank you, AIOS, and thank you, Santan, as well. Thank you.
Thank you, everybody.